This is my colleague Andrzej Krol from ETRA, and he introduced this category workshop for us.
Thank you very much. Good morning, ladies and gentlemen. So I'm on behalf of ESRA, European Society of Regional Anesthesia, and there was a forgotten and pain therapy. Welcome to this workshop, which is well established by Mario Fajardo and his UltraDissection, and a lovely anatomy lab here, and well prepared dissection, most of them by Mario themselves. So congratulations from the beginning. I've been here before. It's well organized, well run course, and it's nice to see, you know, familiar faces from the delegates and the faculty as well. So welcome to this workshop on behalf of ESRA. I don't want to waste too much time, so I will just crack on and start with the first lectures, and I have about 25 minutes to do so. Just to tell you also that we run other courses on ultrasound under the ESRA umbrella. So we have this one, we are here in Madrid, but also we ran the course in February in Innsbruck, and then one in London in March. So everyone is a combination of life model and cannabis, but everyone is slightly different. So if you look at the website, there's a difference how they are run, but the content is similar and it cover the subject. And but if you want to go to another workshops, the Dr. Kovac Marcin is sitting over there, and he is organizing with London Pain Forum and in our support the workshops in Poland associated to Polish Pain Society Annual Congress. And this is the meeting we have been organizing in Poland for, as you can see, 11 years now. And this is the combination. It's not ultrasound fluoroscopy, so some station with fluoroscopy, some station with ultrasound. But also I think this is unique in Europe. We have a station with CT guided procedures. I never had any course in Europe with cannabis to organize the workshops with CT guidance. But we are here to talk about fluoroscopy and ultrasound, because 20 years ago we learned the procedures to do with fluoroscopy guided, and this was the golden standard. About 15 years ago, a few people are woken up, okay, why not to do this with ultrasound? And then has been growing for the last 10 to 15 years, and then you can say there are some weakness and strengths, and then you come to this conclusion that I'm going to show you during these workshops and the lectures today, that in some procedures it will be safer and more precise to do it when you combine both techniques, if you can. So this is from our booklets we've been writing with Barry Nichols and Graham Simpsons and David Silver, and it will tell you about the SWOT analysis. So what is the strength of ultrasound? It's okay, there's no radiation. You can be more selective, more precise in your target. And of course there's a cheaper and portable device. But of course there are some weaknesses as well, because you need another training. So if you are doing for 30 or 40 years fluoroscopy guided procedure, you ask yourself, okay, what I can get from it? You know, I'm perfectly safe and with my technique with fluoroscopy. So then you need to learn the new techniques, and also actually you discover that you have to dig into anatomy to find the new structures, and then you have to learn anatomy a bit more. And there will be some limitation, because the ultrasound is limited by the physics rules. So in obese patients, and there's also artifacts associated with ultrasound, so you need to be reasonable what you can expect from these pictures. But also you have this lot of opportunity, because now you can look and you can think, okay, where is this pain coming from? So you can be more diagnostician in this way, especially when it comes into the musculoskeletal setting. Some of them you can do it in your clinic, so there will be a quick diagnostic, and this is a lot of new technology coming into it. There will be a problem with this when you say, okay, this is what you're looking at, and this is what the target is, but sometimes it's not exactly, so you need to go the pathway and just a way to recognize the structures one by one. So that's and the storage and documentation. In our hospital, we have our pictures for pain intervention we have stored into our PAC system. So we're overcoming these problems easily. So if you look about this combination, when you combine them, what you can look at. So you can look at the spinal intervention, and when you look at the cervical medial branch, I think they're well established now to do it with fluoroscopy and ultrasound, and I'm going to show you that we can do this combined technique. Cervical transforaminal, I always find it very dangerous to do it with fluoroscopy, and I'm going to demonstrate it to you. And the ultrasound, not transforaminal, but extraforaminal, can be equally effective. When you lumbar, transforaminal medial branch, probably there will be limited role of ultrasound, but if you look for the sacroiliac joint and caudal, actually there's a lot of you can do with ultrasound, so I think equally effective. Sympathetic block, you don't need fluoroscopy for stellate ganglion, you just do it with ultrasound. For the celiac, if you do the anterior approach, you only need ultrasound, you don't need fluoroscopy, or you do it with the CT guided. But the lumbar hypogastric plexus, I think I will be able to demonstrate that you can combine these two techniques effectively. And if you look about this musculoskeletal, this is more likely the ultrasound is going to win, because you will see more and you will be more diagnostic, more precise than just using the fluoroscopy. So this is my slide where I was sort of like try to visualize what the ultrasound introduced. So we completely changed our practice in some perspective. Then we increased safety and accuracy with some combination technique. This is completely coming into the old field of chronic pain, all this MSK practice, and recently with this prolotherapy, PRP, becoming more attractive and for the arthritis. There are some studies that, okay, you can use ultrasound for some technique, but actually maybe you stick to the old fluoroscopy. And this is exciting area, especially interested to me is the diagnostic tool, including the nerve injury, when you use the ultrasound for nerve injury. And if you even move further for the peripheral nerve stimulation, we have now these devices which are the wireless, so you can, under ultrasound guidance, you can implant the electrodes for neuromodulation. So this is the opportunity. We're just going to concentrate only on this combination techniques. So as I mentioned, cervical nerve roots, yes, yes, yes. For sacral, I will show you yes, maybe. For lumbar, maybe not. You're going to find out. And the same with the cervical medial branch, I will show you the combination of both techniques. So you take the best of each of it. Intercostal paravertebral, finding the level, this excitement about this rectospinal block, retrolaminar block. We as a chronic pain physician have been doing this for years, targeted for the patient pain. So this is the area with X-ray will tell you exactly the level you're looking at. And the caudal and sacroiliac joint, sympathetic block already mentioned. And the same is new recently, this knee and hip joint denervation. And I think you will need, especially for the hip, still combination with fluoroscopy and ultrasound. Okay, so let's start with the nerve root blocks. Are there any evidence here? There are evidence this is effective treatment, and this is one of the examples when you perform the nerve root block. So 70% patients were responded long term, so avoided operation. For those who had a short-term relief, responded well to operation, but those who didn't respond to the block, they didn't do well with the operation either. So this will give you also the idea to what patient may respond to your treatment. So doing this diagnostic block, if not effective, then it also gives you the prognostic value. And how you do it? All this technique with X-rays I was sweating when even thinking about this. Because you intend to be in the middle of articular pillar and the dorsal root ganglion. So your needle is somewhere around this area when you have a vertebral artery, spinal cord, nerve root, radicular artery, and you were using only X-ray, which is coming into the middle of articular pillar, giving the contrast, and you ignoring all the structures which were around there. And this is one of the slides from our workshop we did with Martin many years ago. You look on this X-ray, it looks fine, but suddenly you are in the spinal cord. So look, and this is only 2.5 centimeters from your skin to the foramina. And if you read about these complications which are happening after interscalene block, they may come from this careless management if you did just with nerve stimulator or sometimes even with ultrasound. But this is what may happen, and this is what stimulated me to do this dissection. And not as good as Mario, but anyway, we were giving the methylene blue and staining the nerve roots, and even extraforaminally, you will see the staining very well after the 1 mil of local anesthetic or contrast. So it was evaluated our technique that extraforaminal are equally effective as transforaminal injection. And this is how we do it in the practice, in the patient in the lateral position. We get a fluoro as well, patient in the lateral position, infiltration with ultrasound. And of course, you will learn from these workshops. I'm not going to go through the details to see, okay, how you differentiate C6 nerve root. And you can see the concept extraforaminal here. Then of course is a technique when you scan to see the C7 nerve root. There's two black holes, one is the vertebral artery, so you're close to the vertebral artery. And when you give a contrast, you will see the transforaminal spread of the local anesthetics. And if you do the pulse radio frequency, also it will be effective treatment. If you go to the sacral nerve roots, yes, it may be helpful, because sometimes if you do the fluoroscopy, you may struggle to see the foramen. There's S1 is usually hidden slightly, so you have to angulate your X-ray. So you're looking at the foramen around here, and then you can see with the ultrasound, you can also identify the foramina. It's a longitudinal view. Okay, this is S1, S2 as a ray of light coming through, and this will be S1 foramen. But if you come, we have to go out of plane technique with your needle, and you will not see the tip of the needle. And it happened to me, you go too far, suddenly the patient will jump because you don't control how deep you can see go with the needle with ultrasound. And of course you want to see the spread of the contrast. Is it how much is going into the epidural space, how much is going to along the nerve roots. So this combination is valued, especially with this in the pelvis. Is a lot of gas, you cannot see the foramina, so ultrasound can help. If you go for the lumbar nerve root, I would say, we stay with the Scotty dog. This is the terrier hours of 15 years, and in grumpy cat, George around here. This is the established technique. When you see the spread of the contrast around the roots, with ultrasound, it's a bit more fuzzy to do it. So probably lumbar nerve roots, I wouldn't recommend it to do it with ultrasound for sure. But whatever the nerve root injection or perineural injection you do, don't forget, and this is what we use in our practice, we're using the pressure monitoring when you inject especially in the neck area, but also in the lumbar area, because first you control, you can exclude your intraneural injection with the low pressure, but also you control the rate of your injection, which may influence the pressure. And the pressure and the rate of injection will influence your spread. Then you will avoid the epidural spread too much, and if you give it too much volume, then you will have a numbness and an epidural block. So this is what you want to avoid. So think about this in your practice. Cervical medial branch. This is something, again, well-established technique to use. Lots of techniques to describe by fluoroscopy, and again, it's effective treatment for patient. Anatomical study has confirmed you need to place your needle in the middle of articular pillar or slightly high up, and with a proper angle to get the medial branch innervating the facet joint above and below. So there's lots of anatomical study, and also the ultrasound described mainly by the group from Switzerland, Andrzej Krol, looking through how you can find out the medial branches. The more distal you go with about C7, C6, it will be less visible with ultrasound, but still doable. But this technique they describe is out of plane technique, if you understand. So you get a longitudinal scan, and you can see the vertebral artery. You may, at the top is C2, C3 joint with third occipital nerve, C3 medial branch, C3, C4 joint. And new technique is from anterior to posterior out of plane. So this is how you put your needle. And then why? Because in front of it you will see the transverse processes and there will be vertebral artery. So again, this technique has to be taken carefully, and also it will be not that good for radiofrequency denervation. This is why Roderick Finlayson, we met him in Porto with Mario a couple of weeks ago. Then you describe this technique when you go in plane from posterior approach, and this is the data of the study he has published. But we were starting, when we're practicing things, you come to this term, okay, you need to do this in a practical term. So why not to combine these two techniques? It makes it easy and effective. So for cervical, I would just say, describe this. So you had the patient in the prone position, and you define your level like that, because you go with C3, C4, C5, C6, C7. That's easy. You can even, as we tried here, from the one entry point to get at least the 3 joints at the same time from the one entry point. But then you want to find out with the longitudinal scan. You can see the valley here where there's the medial branch, but also what is the thing that the most beauty of this technique, you will be looking at the needle along the articular pillar, and you can see the video here. So needle is approaching, and you can see here when you inject. So this is transverse process, posterior part of the transverse process, and this is articular pillar, and you know there's nothing around that. There's no nerve roots, there's no vessel, there's no artery. So it makes you safe to inject or to do the thermal lesion, because you know you scan up and down, there's nothing against your needle, and this is safe to perform this procedure. So we done more than 500 at St. George's Hospital in our pain clinic, and it really built your confidence and safety with no complications. So definitely this is the best to combine fluoroscopy and ultrasound for cervical medial branch denervation and the nerve roots. Sacroiliac joint. Okay, anatomy, we'll be talking about this. It's the largest joint in the body. It's covered by the very dense ligament, but the space itself will be narrowing in time. So the older you are, the smaller the gap is. So often you will go to the joint and you cannot inject because it's so tight, and you have to withdraw. And this is the very valid study, the most recent anatomical study. There were more before from the Toronto group. They describe the posterior sacral network, the branches from S1, S2, and S3, and very random from S4 and L5. And this is how they go around the foramina. So if you think about a blind injection, there was some study how the spread will be into the epidural or sacral foramina, or how inaccurate you can be. So you will be doing the ultrasound guided technique, and depends on the patient, you will take a different probe. You will be seeing the cleft or just the gap in the joint, and then you will be approaching from medial to lateral. So this is how you can do it with ultrasound, and you can compare. I like this study, and there was one of the 10 years ago, there was only 10 publications about the sacroiliac joint injection with ultrasound, and the results were interesting because they were only accurate in 60% in the first 30 injections, but the next 30 they would be almost 100%, 93% accurate with the injection. So if you have this combination, you can start with ultrasound and verify it with fluoroscopy, and you will get your confidence very, very quickly. And again, this is one of the very, very effective treatment. And still I was thinking, okay, well, why you can not combine, especially when you do the denervation of the joints. I call it barbecue of the joint. And we're using the Simplicity probe, which is quite big and aggressive probe, with slightly curved. So when you think about it, okay, if I only use the fluoroscopy, I'm a bit scared to use it, because if you go to the foramen or you go to the pelvis, you may go sort of like a serious injury. So we describe this technique that you scan in a methodic way. So you get a sacrocoronal around here. It always looks the same. You always find them, regardless the patient. You turn the probe slightly lateral. You will see the S4 foramen. So you want to be slightly lateral from the foramen. But at the same time, I try to see where is the line of the joint. because this is my lateral border. So I even make a mark on the skin. Then you can go for the longitudinal scan, as you can see here, and you can see the foramina. So you don't want to go with the probe with the foramina. So you just slightly more lateral, and then you will see the surface of the sacrum. It will give you the idea where's your entry point, and the nerves, you know, from this anatomical study, they run through very close to the periosteum. So you just place your probe, so you reduce the radiation, you increase your confidence and it's safety for the patient, and it's become sort of like from scary technique, very simple and reproducible. So, and to look through this, it's worthwhile. Caudal epidural is easy when you look through the scanner, longitudinal scan. In a young patient, you can see the needle going through, but in some patients, then you be not that easy. I don't know how about you, but in obese patient, I was struggling to get with the fluoroscopy to get into the foramen, and then, you know, giving the contrast and it's not in, and you spread and you try to adjust. With ultrasound, even with the most difficult one, you always see this sign, and then you will be easier to get into the space. Okay, last 5 minutes. I'm going just to talk about the sympathetic blocks. So I mentioned to you the stellate is ultrasound, celiac plexus is ultrasound or CT, but for the lumbar sympathectomy you can nicely combine the both techniques. So you want to be at the level, as you can see, usually L2, L3, you can see the contrast L4, or the king ganglion is at the level of L2. So this is where you aim, and you were using just the fluoroscopy technique with your angle, but with your approach with ultrasound, this is nothing different from the shamrock approach you had with the lumbar plexus, because this is the transverse process, this is the vertebral body, this is the psoas muscle around here, and your needle has to be on the anterolateral part of the vertebral body. But with the fluoroscopy, you don't see, you have to see the iliac vessels around here, so you have to carefully adjust your needle. So there's a place for lumbar sympathectomy to use combined technique, and the same for the superior hypogastric plexus, and this is what we described with my colleagues from Poland. With slightly angulated probe, you can again see the transverse process, vertebral body, and you can adjust your needle, but you need to use a contrast with X-ray to confirm, to see the spread, and then you are in the right level. But ultrasound will help you to get this initial angle and to go into the vertebral body. And ganglion impala, if you do this ganglion, again you will need fluoroscopy, and ultrasound may help you to find out, as you can hear, you can find out the space, this transcoccygeal ligament. Probably you will need the hockey stick needle to get there, because otherwise it's quite narrow. But you want to see the spread of the contrast when you go through the ligament, that you are not perforating the rectum and you're not still in the ligament, just to see the contrast for the spread. And just very quickly, for the last 2-3 minutes, we'll tell you about the knee joint and genicular nerves. So again, when there was the first paper described by the Korean study about this superior lateral, superior medial, inferior medial genicular nerves with the fluoroscopy, we were thinking in our clinic, okay, what fluoroscopy, can we do it with ultrasound? Of course we do. I think there was one of the first description when you scan, and you can see this indentation and junction between the shaft and epicondyle in the longitudinal view in all of this location. Often it helps that you can see the artery which is pulsating. You may not see the nerve saying, oh, this is the nerve. May not be like this, but at least you can reliably find out this junction. And this technique we describe you at this point. When you find it, you turn the probe 90 degrees, and then you put your needle across the junction. This movement, sometimes you have to be very precise to make sure, because if you move it slightly up and down, then you may lose it will be 1 or 2 millimeters farther away. So this is like a more description of this from our booklet. When you scan superior lateral, superior medial, inferior medial, this is how it looks like. You can again confirm with the fluoroscopy. And this is our recent study with team at St. George's when we did the dissection, and we just were looking for the size of the radio frequency. There was just 0.1 mil of contrast given for the inferior medial was very precise. Superior lateral, the more about 10 millimeters difference was for the superior medial. So this will tell you what lesion size you need to have to get this net. And I'm not going to go into this anatomy. You read the newest papers about there's more than these 3 nerves. They branching, they coming from different origin, but reliably there are nerves going to the joint at this level. And the last one is a hot topic is the hip joint. To start with, you need to, and with ultrasound it's very easy to do this intra-articular injection. And probably you cannot go to the denervation of the joints without practicing this technique for the hip injection. And in fact, the first injection you do in the people with osteoarthritis can be very effective. So you don't even 6 months to give a steroids or whatever you give it, there will be good effect. So this is the easy technique you can do with ultrasound. You can see this is anterior recess. You can see the needle here, and you can see the spread, and then it can be very, very, very effective treatment. Now, if you think about the denervation, so that this is from our practice, the X-ray, but this is, I think, well elegantly described from the Philip Peng group. And then probably we may practice this. So anterior superior iliac spine is easy to find. You go to the anterior inferior iliac spine, it's easy to find. You turn the probe, and then you will be along the acetabulum iliopectoral eminence, and this is the way the branches lie of the femoral nerve innervating the joint. So this is how you put your needle, and it's good to verify this with fluoroscopy to your end point, but also you will need to watch out, to avoid injection around artery and nerve around here. So this is why you need to combine these two techniques, not to be focused on your target and then you miss that you go to the artery or you go to the nerve. So this is when you go for the femoral branches, and then this third drops is that when you're looking for the obturator branch to the joint, again radiologically very defined point, but when you think about the ultrasound it's not that easy to get there. But when you start with your classic approach to the joint, so this is femoral head, and this is the acetabulum one here, and the femoral neck. So so this is the position you get here. So this is your classic position for the periatrical injection. You go medially, so inferior medial acetabulum, then you will identify the point when you go around the third drops. And how to get there. So there's a few techniques described. Nothing of them is 100% proven, because you need to every time be innovative and inventive to get to the end point using your ultrasound. And this is what we're going to practice. I think more or less on time. Thank you very much. And we're going to have one more lecture, and I'm going to practice on the kids. Thank you.
Go to www.ultradissection.com or info@ultradissection.com.